addiction. And we wanted to start off with this because it's a real game changer. For myself, when I was a practicing physician and a medical director of a clinic, the way we thought about pain and the risk of addiction 15 years ago was very different than we think about now. The way we think about the risks of opioids on the brain and on the ability to function is very different. And our understanding of how well they actually work in chronic pain. We made a lot of assumptions about how effective opioids are in the long term and how, all those assumptions are being challenged. So that's why we're going into this topic now. As a Train the Trainer program, keep in mind we're not trying to do a total content dump now. What our goal is to go over some content, give you some examples of resources that you can use as faculty with your own residents and you can use as you think about setting up a safe prescribing culture in your clinics. And then we're going to make brief reference to certain topics that you'll be able to do a deeper dive on our Basecamp website. So, for example, Shona Abramovich, who's a psychiatrist and a specialist in addiction, is going to be walking through the bulk of the webinar. She's got 2 hours of a very excellent slide deck that you are welcome to use, and she's going to be going through parts of that slide deck, but not nearly in the level of detail that we would if we had more time. Likewise, she's going to be highlighting resources that are on the Scope of Pain website, including videos that can be used to trigger discussions and case review. And we're also going to be going through a video that Dr. Corey Waller has available on YouTube that is, again, a real a profound way to think differently about pain and addiction. So we'll be giving you a 6-minute snapshot that will be available to you later. I want to also let you know that Corey Waller is developing a big website with over 200 5-minute videos that will be available starting in October that are specifically how to manage different topics within pain and addiction and complex populations. So that'll be another resource available to you. So that's our orientation. I, again, wanted to remind you about our faculty, and Shona Abramovich is going to be our faculty today. And Christine, do you want to walk through our agenda?
Sure. So I'll have some housekeeping items and talk about accreditation for this webinar. We will also go over sort of the expectations for developing SMART goals and some action plans. And then we'll go into Sharon's talk. At the end, I'll just go over a reminder of some calendar dates, and we'll have a lot of time for questions. So many of you, I think almost all of you, have been working on your SMART goals. I had the opportunity to be on coaching calls with most of you over the last couple of days, and the SMART goals are looking really good, and we have been discussing ways to improve the SMART goals and make them even smarter. We're going to spend a lot more time looking at the improvement models and refining your SMART goals at a future webinar, the one that we'll have in August. But here are just a couple of examples that have been coming through so far of SMART goals. Some of our next steps is, once we have worked together to refine your SMART goals, we'll be working on your measures and your action plan. So we'll be talking a lot more about that in the next webinar, and I'm going to give you an example of a work plan in the next slide. Other next steps are we continue to encourage you to learn from others in our action group community, and of course you've got your support from our faculty and from me, your coach. So here's just an example of an Excel work plan. I'm sure many of you are familiar with it, but if not, feel free when you get this PowerPoint to just take this template and make a copy for yourself, and this is also something that we can work on together in our coaching calls.
I'll just step in for a second and just say that several people have asked, where do I find clinical guidelines, or I don't want to start from scratch for our own protocols. And that's why we put together this couple-page resource list that's on Basecamp. And the most comprehensive and full of tools, amazing compilation is the Southern Oregon Guidelines. The Medical Board of California, of course, are the ones that we go by, but they have a few less resources. And finally, we took from the Southern Oregon Guidelines, we took their one-pager, which is essentially how do you do safe prescribing guidelines in a clinic, all on one page, and that's available for you as well, just because sometimes when you look at the Medical Board of California, is 20-plus pages. It can feel overwhelming. So if you need to just start simply and start somewhere, this is a really good flow sheet. And again, that will be available to you, and you're welcome to adapt it and put your own logo on. Our goal is to give you resources as faculty, to not necessarily teach you as students, although we'll be doing a little bit of that in this webinar today, but again, to give you tools that you can then use and adapt yourself. So we're showing 2 examples of videos today, one with Corey Waller. We're giving an example of a whole suite of 200-plus videos that are 5 minutes long that will be available in October. Sharon will show you some videos on scope of pain. Sharon's full 2-hour teaching deck will be on Basecamp that you're welcome to use, and Scope also has some tools that if you go through their Train the Trainer program that they can make use for you. And again, we're recommending the more interactive the better. These are tough conversations and tough patients, so role plays and shadowing with feedback can be very effective as well. So then, do you want to head over to the Corey Waller video? So what we want to try and do is have you check out this link as to kick off our training on neurobiology of addiction. If you take the link that is in the chat box and hit it, you'll go to a 6-minute video from Corey Waller. I'm actually thinking, given that we started late, why don't we skip that and have you do that separately? But it's really worth seeing the 6-minute video or the full 40-minute video. In fact, I encourage people to do it on their commute. It's mostly a talking head, but he's an incredible speaker. He's very dynamic, and he has a very interesting way of portraying what happens to the brain with chronic opioid use that really changed my own perspective of how I think of my patients. So to summarize what he says, for example, our primary motivators in life are food, water, and dopamine, and that dopamine is the main driving force for everything we do. And he gives some great examples. So if you are sitting on a beach and had the best day of your life and you've got a 2% body fat and you've just fallen in love, your dopamine level might go to something like 60 or 80. If you've had a cigarette, it goes to 100. If you have methamphetamine, it goes to something like 800. I'm getting the numbers a little bit wrong, but the bottom line is taking methamphetamine or opioids, almost any street drug will get you to hundreds of times the level that you can get on your own. And so, of course, if you're doing that on a daily basis, you blow your ability of your brain to make dopamine anymore. Just like if your pancreas breaks and you need external insulin, it's a similar way of thinking of how the brain can break, not be able to produce its own dopamine if you've used opioids long enough and high enough. And so that brain can heal over time for many people, and that's why opioid replacement therapy has got so much evidence behind it, because just like replacing insulin, if you have a brain that doesn't produce dopamine and you replace that dopamine and allow them enough time to rebuild their life and learn new habits and learn to cope, then some people can get off of it completely, but not in 2 months or 3 months. And that's what we're finding, a lot of mistakes happening. As we get onto safe prescribing, a lot of doctors are saying this isn't safe anymore or you made a mistake and we're going to wean you off in 2 months, and it's surprise, surprise, the people can't cope, can't organize themselves, can't think day to day about how to get things done and end up turning to street drugs or heroin. So as we set up safe prescribing cultures, it's really important that we understand how the neurobiology of opioids work and therefore make treatment plans that then make sense. And one of my favorite lines is he says, if you've got a diabetic who comes in having binged on Krispy Kremes, comes in with a sugar of 400, we don't fire them from our practice. But if we have someone who we've put on opioids for years and years and years, they can't make their own dopamine, something happens, they run out of pills, they buy a Vicodin from a friend, and we consider it a moral issue and fire them from the practice. And so this is really the attitude we want to change. So again, I encourage you on your own time to go to that link for the 6-minute version, or just Google Corey Waller YouTube and go to the full 40 minutes. It's really valuable. And I'm going to turn the deck over to Sharon. Take it from here.
Okay, hi. Well, I am absolutely delighted to finally get to meet you all, even if it's remotely. And I'm actually looking forward to coaching some of you and meeting you all in person eventually. So, hello. So, as Kelly said, I'm showing sample slides from a 2-hour small group training that I do with all our R2s in our internal medicine program at Highland Hospital. So that full deck of slides is again available on Basecamp, and you're welcome to use it. I want to thank Dan Alford because I certainly lifted some of his slides into my slide thing. So this is all, you know, we're all going to be co-creating these trainings and teachings, and that's great. So in this talk, we're going to try to convey an overall philosophy that we think would be important for you to convey to your trainees. First, pain and addiction share overlapping neurobiological pathways, okay? And the Corey Waller talk explains that very well. So we're not going to be focusing on that in detail today. Secondly, what we will be focusing on is that pain and addiction are on a spectrum from problem use to substance use disorder to addictive illness. This is very different than, you know, people have conceptualized in the past. They've seen, you know, some pain patients get addicted, others don't. It's some sort of either or. It is not an either or. This is a very important thing to convey to our trainees. It is a spectrum of use. Why is that? It's because opioids always cause physical dependency. They always downregulate the opioid and dopamine systems. That's going to occur for any of us after actually a few weeks of use. It's just that vulnerable patients go further down that path of a broken brain. I mean, frankly, chronic opioid use breaks the brain to some degree. It's just that some people's brains get more broken, and at the extreme end, they can get a substance use disorder. And finally, in my opinion, maybe the most important thing is we want to stress empathy. This is a stigmatized issue. People are stressed by it, and empathy both for our patients, of course, but also for the clinicians is really quite important. All right, look at this image. This is an image for me that represents what happens when we're dealing with these patients and how we feel inside. I don't know if you all relate to it, but for me, when I start this kind of training with our residents, in order to help them to empathize with chronic pain patients, I want to first help them to empathize. I want to first empathize with them and what they're going through. So I like to begin by letting residents discuss their experience of being caught between this rock and a hard place. And, you know, in psychology, we use a term called parallel process. And, in fact, the residents and patients are having a parallel process. Both want the patient to feel better, but they keep hitting limits of the opioid treatment for chronic pain. Because, one, you know, opioids can provide immediate pain relief. I certainly experienced that when I had a bad ski injury and a snowboarder ran into me. I lost my spleen. Thank God for the 6 days of opioids I used. It was a godsend. But over the long run, they're limited when used as a monotherapy for chronic pain because they cause problematic neuroadaptation that often prolongs the pain experience in ways that the patient does not connect with the fact that it's due to the opioids, okay? So patients experience immediate relief, even on chronic opioid therapy. You know, they'll take their Vicodin and for various reasons experience immediate relief. And without proper education, they can't understand why you're denying them this really useful medication. So the topics covered in the slide deck and what we're going to go through just give you kind of a little taste of is the scope of the problem, the evidence for long-term use of opioids, rational opioid prescribing approach, problem use due to opioid prescribing, problem use due to substance abuse, integrating Suboxone into primary care and prevention. Okay, chronic pain, as you all know, is often a comorbid condition that intersects with emotional suffering. Look, we are not, despite Western medicine's approach, our mind and our body are not separated. We're mind-body creatures. Emotional and physical pain intersect always. And it's really two dimensions of the same phenomena. And we want to encourage residents to pay attention to these comorbidities because if they don't, chronic pain often doesn't improve. So remember, the body is not experienced as a separate entity inside ourselves as human beings. It's experienced as a body self. Now, as Kelly mentioned, when I teach, I downloaded, in a much harder way, actually. I really like that. I've just learned from Christine a simpler way. But anyway, I downloaded from the Scope of Pain website these videos, and we instead of running this one that actually Dan uses in his Scope of Pain training, you can go online and, you know, you heard about all the ways to access this. So anyway, These videos will be reviewed in detail in the October 1st training, but these are great, these kind of videos, and let me go on to the next slide. So you can see there's discussion tools and all that, or you can make, for me, I just make up my own discussion, but you can choose these various topics. Look at these topics. Look, these are the topics that everyone's struggling with in these challenging patient-doctor interactions. And you can run the video, you can watch the patient and doctor interact, you can stop the video and then have, which is what I do, have the residents discuss what's going on and their impression. And then if you want, you can even run, right after that, there's a video that shows Dan and his colleagues discussing what just happened. So it's a really great interactive teaching tool. It brings the clinical experience right into the room, into your teaching with your residents. All right, let's go on to the second topic, which is evidence for long-term use of opioids. Okay, so we know this, and here's a really great teaching hook. I think it's important to lay out this paradox, and it really is a good teaching hook. Okay, from 1999 to 2010, the sale of prescription painkillers quadrupled. Now, it made making it actually the most prescribed class of drugs in America. In fact, I like to ask residents, what do you think is the most prescribed class of drugs in America? America, they'll say hydrochlorothiazide, they'll say lipid drugs, and it's actually like Vicodin, frankly. And yet it doesn't work for the very thing we're prescribing, which is chronic pain. Why? Well, my cynical answer is Purdue Pharma made a lot of money off of it and manipulated the system. But going beyond that, the reason is that the neuropharmacology of opioids, is a paradox. And chronic pain is a mind-body illness that we can't treat just with pharmaceuticals alone. We can't just treat obesity, diabetes. It's one of many. And Western medicine is very caught up in, pharmaceutical reductionism. I think chronic pain is the, ultimate example of why we need a more integrative approach with many of our chronic conditions. So here's the point, and this is the hook to help people, get moving into a different direction on this. Okay, so it's important to understand where opioids are and are not useful. Now, frankly, I think, Kelly, I don't know if you probably would agree with me on this. Frankly, opioids for chronic pain probably are generally not useful. Right. But here's the problem. We have a lot of patients, millions and millions, who are on chronic opioids for many years. And at this point, in some ways their brain kind of has adapted to it and need it. So we got to deal with that. But this is also, we've got young clinicians you're training, and we don't want to add more people to that cohort. So we're going to take the stand, would you agree, Kelly, that very few of our patients are actually appropriately going to need, at the start, opioids for chronic pain. And
I was at a conference once where there was probably 200 people in the room, and someone said, can you raise your hand if you've ever cured or made better someone with low back pain, fibromyalgia, or migraines using daily opioid therapy? Of course, no one raised their hands, and it's so difficult for residents to understand because you feel better when you take a Vicodin in the moment, but then long-term, they just don't work.
Okay, so what are opioids useful? Obviously for acute pain, and back in the last century when I was doing training in some internal medicine, we would give a few PRN opioids, 5 to 10 a month for acute short-term low back pain flares. And I still would say that's fine, in patients where there's not a safety risk. And then, of course, there's other classes of pain meds that are equally useful or not, all right? Okay, so this is a retrospective study that was done in Boston and looks back at patient files over a 7-year period to determine what effect dose adjustments had on patients. Now, all 109 patients had no documented change in their pain conditions, so it's not like some were getting sicker or others better, okay? The average morphine equivalent dose was around 175 milligrams with an average pain score of about 6.5. And over 7 years, a third of these patients decreased their dose, 45% increased their dose, and 20% had no change. So what it showed was that increases in the opioid dosage actually had no effect on the clinical pain score. Okay, and this is kind of what your audience just said. So it's also true when we split it. This is interesting because we were always taught, well, use opioids for nociceptive pain, not neuropathic pain. Well, it turned out it wasn't true for either neuropathic pain, that's not surprising, nociceptive pain, and mixed pain conditions.
And what I was always taught is, keep upping at the dose until you get to a pain score of 3 out of 10. And I remember looking years later and figuring out the patients who were 8 out of 10 were always 8 out of 10, no matter how much pain that occurred.
That's right. So we're going to have a taste of rational opioid prescribing approach. Now, this is work done by Gourlay and Haidt, and I like this because universal precautions is a good metaphor because I think residents are comfortable with this concept from infectious disease. And if you are going to go down the road of prescribing opioids for chronic pain, these elements should be incorporated into a prescription pain medicine agreement. Now, residents will easily revert to the term contract here. Very important to correct them, actually, and get them to say agreement. Reason, it's not a contract. It's not legally binding. Every patient's different. There has to be some flexibility. Really, what this is, it's an agreement for physicians or clinicians and patients to collaborate. So it's saying, we clinicians have a certain responsibility, but also you patients have a certain responsibility, and we're going to work together. And importantly, I really believe that these agreements should be hooked up with informed consent agreements, because this is your chance to actually help our patients understand exactly what the complications and side effects of these drugs are before starting a trial of them. And that's so not done, and that has to be changed. It's just because I do consults on patients later down the line, and at least they don't remember ever having that discussed. Okay.
And so it's along with being a vehicle for informed consent, by using that word agreement, you get people out of the temptation to fire patients when they have difficulty keeping to the terms of agreement or don't remember the agreement, or use the certain behaviors of addiction. And by firing someone because they have the symptoms of a chronic disease, we're really not doing good medicine.
Yes, very important point. Thank you. Okay, this is a picture of the opioid risk tool, and it's now becoming, I would say, the standard of care screening for this issue. So this is something you want to do before, let's say, okay, I am going to go down the road of opioid trial for chronic pain. You need to do this tool. This tool takes about 5 minutes. Now, it doesn't mean you won't prescribe chronic opioid therapy, but it needs to be a part of the risk-benefit assessment. These questions, as you can see, are quite sensitive. So it's not something you're going to just hand to the patient and let them fill out. You have to do it verbally, and it's done by a provider, and it needs to be done by a provider trained to be sensitive to these kinds of questions. That could be the physician, but it also could be a nurse, a clinical pharmacist, a health coach, an MA. You would also, we'll talk about this a little bit later too, but I would also ask, have you ever been harmed sexually, physically, or emotionally as a child or adult? Because this also increases risk. And if this trauma ends up in a post-traumatic stress disorder syndrome, it further increases risk. So what does risk level do? What does coming up with low risk, moderate risk, high risk does? It helps you to tier how intensely you need to monitor the patients. And this is now becoming, again, the standard of practice. So here's a recommended approach to monitoring depending on the risk level. If they're low risk, the patient can be seen every 3 months, managed by the primary care provider with routine cures, urine drug screening, and an annual review of pain agreement. If they're medium risk, you do the above. And medium risk people would be, let's say they have a past history of substance use disorder, they're recovering alcoholic or something like that. They're not actively addicted right now. Then the primary care provider should get probably behavioral health consultation, or maybe there's a review committee support. And then monthly, the person's probably going to need to be seen monthly with more frequent monitoring of the ones I've just mentioned, including adding pill counts. For a high-risk patient, now that would be someone who's actively addicted or abusing, and not just opiates, actually any kind of drugs, cocaine, alcohol, etc. Or they have an unstable major psychiatric disorder, that person should either be in a narcotic treatment program, some other substance use disorder program, or mental health treatment, and managed in that way. And, or, you know, hopefully most of you will become primary care providers with Suboxone on the X license, and you can do that, manage those patients with behavioral health treatment inside your clinic. That would be the ideal someday. All right. Now, when you're going to start opioid trial, I want to say this with capital letters. It's a test. T-E-S-T, a test. It's not something you're committing to forever. You're seeing whether or not it's going to benefit. Using the SMART goals, like you're using for your QI projects for this collaborative, is a good way of thinking about this test. You're going to test, what's your specific goal? What is it measurable? What's the action that's going to be taken? What's realistic, time dependent, okay? On a website I do as a volunteer project for providers in Alameda County who are serving the underserved. It's www.pcbehavioralhealth.com. Under the download section, there's a form called the Pain Disability Index, and it's used in a lot of pain clinics. It's one page that assesses functional domains that the patient can fill out themselves. These sort of check-off boxes. Now, I give this to the patients when I do consults or have our residents do, and often the patients will rank everything really, really fine because they're trying to make an argument to you that you should be giving them these opioids. So being strategic here, I like when that happens because then I can use it as an argument that the opioids aren't working. A little manipulative, but, you know, it's kind of true. It's not, you know, it is what it is. Another approach you can take is using a brief motivational interviewing tool called a typical day. So a typical day, you say to the patient, hey, I want you to think of a, you know, typical day you went through where there wasn't anything too odd going on in the last week. Let them think about it. And then say, let's, you know, think about your social activities, your physical activities like exercise and so on, tasks, work, and also what medications you took or any recreational, you know, substances you use to manage your pain. So let's start in the morning, and they run through the day. This actually only takes about 5 minutes, but I'm telling you, that narrative, that open-ended narrative, will give you a really good sense of whether this patient's pain and opioid treatments and everything else is actually helping them to function better or not. Because believe me, when I've done this, I've heard people just laying around absolutely sounding like they're in an opium den, you know, versus people who are really quite active, and it really gives you a good sense of what's going on. Okay, so setting goals. So now we're going to go ahead and start this trial, this, you know, just this test. And what are we going to look at? We got to look at something. What's our outcomes here? So this is the 4 A's of, you know, it comes from the pain treatment world. And first is analgesia, and again, this gets overemphasized, frankly, but, you know, is the patient obviously getting some adequate pain relief? This one, the next one I would say is, you know, the most important, which is what we were just talking about, activities of daily living. Also, you have to look, is there adverse events going on that means, no, this is not a successful trial, or is there aberrant medication-relating behavior? So let's look over the top 5 high-risk opioid prescribing behaviors, okay? If high doses of morphine equivalents that be greater than 120, I would even say greater than 100, frankly, but that's a common threshold. And the more dose, morphine equivalent dose you give of opiates, prescription opiates, the more risk there is. Methadone obviously is a high-risk drug, and particularly over 40 milligrams, and especially when you combine methadone with other opioids, which often happens. You know, there's a short-acting you give for breakthrough pain, and then there's long-acting. That's what I've seen. That's a really dangerous combination for accidental ODs. And then, of course, there's benzodiazepines and opioids and use with alcohol. Again, really dangerous combination. I've had patients, I remember a patient coming in, he had been on benzos and opioids, and he drinks a bit, and he says, doctor, I haven't dropped dead so far. I said, right, glad you're here. But what you have to emphasize, and this is, I've heard this several times, what you have to emphasize with patients is that accidental overdose is not that you are going to take it, it's that your brain all of a sudden is going to do something weird with this, and we cannot predict that. So that's really important to emphasize. Obviously, multiple prescribers, you've got to check cures. And here's a really interesting statistic to share with your residents. When you take patients and they end up on these drugs for over 90 days of continuous use, this is horrifying. Half of these patients are now going to become lifelong users. That is a great risk and something, you know, we're throwing patients down a road that's going to change their life. So, again, you know, this is important that patients understand this before the trial is even started.
We wanted to call out these particular high-risk practices because in a few months when you log on to Cures, you'll start seeing scorecards or reports of all of your patients with opioids longer than 90 days. With the thought is that if you are prescribing someone, sometimes you don't realize you've hit that 90-day cliff, and it's good to have a conversation about getting those folks off opioids so they don't become lifelong users. You'll see all the people who are using multiple prescribers, and instead of having to log on for every patient, you'll be able to see a list of all your patients. So all of the ones that are listed as high risk will be highlighted in Cures once that new functionality is up.
Okay. These templates will be reviewed in detail on October 1st, and we can connect you with examples based on your type of medical record. Obviously, there's different types of medical records out there. So anyway, these are possibilities, okay, and we'll help you with that.
And the reason we bring that up is obviously for busy PCPs or residents, if there's not a system to support you doing the same thing consistently, it won't happen. So the more that you set up a system of care where either your team does certain roles or your EHR template drives certain behaviors, it helps make sure that you create the culture of safety and that it's
yeah, I think EHR you know, driven pop-ups is vital, frankly. I don't think it's going to happen without that. Okay. And these are other topics on the slide deck that we'll review in detail on October 1st, pain management agreements, urine drug screens, Cures, best practices on refills, pill counts, and other monitoring strategies.
So we'll just pause for a second for people who join late. Again, our goal was not to hit all the topics in this call, but to be able to highlight things, to teach residents, and to give you resources. So for those who arrived late, all of these slides are available on Basecamp, as well as some videos that you can use. Does anyone have any questions or comments before we go forward?
Can you hear me?
Yes.
Yes.
Okay. I had a question about your consent process for starting a narcotic for an acute problem. Were you suggesting that we fully consent about all the side effects, et cetera, when starting Norco for a week, for instance, for an acute problem?
No, I think you only have to consent for whatever the issues are for a week. They're different. See, really, these are, in a weird way, opioids are two different kinds of drugs. There's an acute, you know, less than a week, frankly, and then, you know, longer. They really require different. There's different risks and benefits, and so your consent should parallel that.
So most people wouldn't have people sign like a 2-page consent form, but certainly you'd want to go through risk of addiction with long-term use, so people understand that why you're just restricting short-term, not because you're a mean provider, but that it really changes the brain long-term and people become dependent. Risk of teenagers and others taking them, so making sure they're locked up and secure. Risk of mixing with alcohol, risk of impairment while driving. I mean, all these things would be important to review verbally, but I haven't seen anyone try and set up forms for short-term.
Yeah, and I want to emphasize, again, please ask all your patients to lock up their abusable prescription drugs, everything from Adderall to opioids, okay? Because that is the access for youth, okay?
Any other questions before we go forward?
Okay. All right, now we're going to look at problem use due to opioid prescribing, and okay, so this is, again, this is a nice graphic showing this is a spectrum problem, okay, from problem use all the way to substance use disorder. And most chronic pain patients on long-term opioids do not have an addictive illness. The likelihood with chronic pain becoming addicted to opioids is low, with the exception, as we spoke about, of people who have those epigenetics, personal or family history of drug abuse or other mental illness. You know, many patients are going to use these drugs for non-medical reasons. Let's say they're depressed. Opioids give a little bit of a euphoric effect, and so someone may realize, wow, when I take my Vicodin for my back pain, I also feel a little bit better and I'm feeling down. Especially with underserved patients where they don't have a lot of access to any other treatment. But regardless, any non-medical use of psychoactive medications can be harmful. Okay, chronic opioid therapy, obviously, and this is the tricky part, and it's important our residents understand this, and then the residents can, and once they really get this in their bones, and they can explain this well to patients, that yes, it works in the immediate sense, but overall it can worsen, and often does worsen the pain experience through these three mechanisms. It causes endogenous opioid and dopamine systems and other systems to neuroadapt. Think about it this way. The body goes for balance. The brain goes for balance. If you're getting something exogenous on a chronic basis, as I explained to residents, then the brain adapts and it starts to balance, to go to balance. And when you start to, when the neuroreceptors start to downregulate, you get, first of all, tolerance, especially in younger patients. So they need more medication in order to get the same effect. And, you know, you can have the residents relate to it through their drinking, possibly. You know, let them relate to this. This isn't just unique to opioids. And if a dose is skipped, or, you know, even within a day or within a few hours, they get withdrawal. And let me just mention about withdrawal. This is important. Many of our underserved patients don't have the money to pay copays, so they skip getting their medicine for a little while. Or they have very complicated lives and they can't get to the pharmacy, or they can't get to the clinic to do what they have to do. So they go into early withdrawal. Here is the COW scale, which is the clinical opiate withdrawal scale, all right? If you look at that, in early withdrawal, you get anxiety and bone and joint pain, which is often confusing for the patient and even the provider if you're not understanding this, that this gets confused with the worsening underlying pain problem. I see this happen all the time because people don't understand the withdrawal. And withdrawal happens, again, within several hours of missing a dose. So this is normal. We're all going to get this if we were to take it, as long as our patients take it. Another thing is, you know, look at their pupils. Are their pupils dilated? Are they saying, well, God, doctor, I'm in so much pain, I need my pain medicine? And you know, just glance at their pupils. Dilated pupils will also tell you they're in withdrawal. So we see tolerance, intermittent withdrawal, and hyperalgesia. All those things can occur on chronic opiate therapies and actually worsen the pain experience, although it is not subjectively understood by the patient because it's not sequential. It's more indirect.
And this can be very helpful to talk to patients about when you're talking to them, either the risks of increasing doses or when you're trying to work with someone to wean their doses down, because patients get so convinced they need it because every several hours they have pain when the pain's actually due to the withdrawal, not their original injury. Or especially the people who say, do you hurt? Yes, I hurt all over. What about your fingernails? You know, my fingernails hurt the worst. But those are the hyperalgesia patients who are actually creating pain by using the opioids. And those are the people you can cure by getting them off opioids. It may take 6 months or a year. Usually people, because of how their brain adapts, don't get off of them in 3 months. Many of them do much better on buprenorphine because buprenorphine both controls the pain. It gets people out of that withdrawal cycle, and again, is much more stabilizing. So we'll have a talk later by Dr. Andrew Rubenstein that's specifically focused on how to engage patients in agreeing to tapering regimens. And one of her main messages is just really coaching people about your goal is not to get them off opioids because you think they're an addict. Your goal is to get them off opioids because it'll make the pain better, it'll help them have more energy. It may take away medical illnesses like sleep apnea or hypogonadism or other things that can't come up. But again, it's important to understand that.
And hyperalgesia is really difficult to wrap your head around, that these drugs can cause it. But if you use the metaphor of you have a broken pain system because of taking these medicines and the adaptation, and now it's so broken you don't have a way to fight pain, so we're going to have to allow your brain to heal. And this doesn't occur just with opioids. It can occur with chronic Tylenol use, chronic NSAID use. You see this in headache clinics all the time. It is not just with opioids. So, you know, there's other issues here, all right?
So any questions or comments about that? So again, we're going through a lot of detail fairly fast. There's a lot more slides and more detail in the base camp, and also October 1st when we'll meet in person. So it'll much more facilitate these types of discussions where we can then sit down and talk about how to adapt this learning to your own environment.
Okay, now let's talk about problem use due to substance abuse. So I like to make sure with residents that they understand something about epigenetics and the risk for substance use disorder and what that is. So they probably know better than I because they've been through biology more recently, but let's review it, okay? So when gene transcription is altered, it's altered not only by inherited genetics, but it's also altered by, neurobiological stresses that occur after birth, maybe even in utero, but certainly throughout the course of life, and even environmental factors. So with substance use disorders, our understanding is, okay, yes, you have to have some sort of genetic vulnerability, but what turns that gene on and off? First of all, you'd have to have exposure to the substance, right? Okay, that's a given. And we know that the majority of substance use disorders, certainly not all of them, but the majority have had histories of significant trauma. And that trauma causes stress. That stress causes serious neurobiological change over time. And so a pattern of risk then alters genes expressions for vulnerable patients. And the important message is what you do to your body and mind can alter your gene expression. And this can be seen in this wonderful study. Hopefully most of you have been exposed to it. It's the ACE study, the Adverse Childhood Event Study. It was one of the largest investigations ever conducted to assess associations between childhood maltreatment and later life health and well-being. And it involved 17,000 Kaiser patients. So these were not just, low income, we were kind of really middle-class population, covered a lot of SES levels. Completing a questionnaire about childhood maltreatment and family dysfunction. So despite your SES level, they found a high association between increased adverse child events and substance use disorder, alcohol use disorder, depression, and adult chronic diseases such as coronary artery disease, diabetes, obesity, etc. So it's useful to ask all patients again, have you ever been harmed physically, sexually, emotionally as a child or an adult? Because their risk for all kinds of chronic disease, including chronic pain, etc., goes up.
And I'll just say one thing on this, getting back to Corey Waller, he's set up a clinic in Grand Rapids, which you can learn more about by clicking on the link that's earlier in the chat box. Well, what they've taught all of their staff and their clinicians about this concept of trauma-informed care, which many of you have heard about. And he would give an example of a patient who was in the emergency room again for addiction and requesting opioids, and a very kind nurse touched him on the shoulder, and he went out and belted them and knocked him over and created this big issue. Ended up being committed, and the whole piece that was not understood is that he had been sexually abused, so that touch on the shoulder was not a benign thing. That touch on the shoulder was an assault. So by teaching residents and staff how to recognize when people have had trauma, how to de-escalate, how to only touch someone by asking permission, to kind of have this awareness that this history of trauma may actually create some of the behaviors that then we lead us to say, well, we're going to fire this patient from the clinic, they're violent, when we may have precipitated and escalated that by making them feel unsafe, by cornering them, by these types of things. We'll have time to go into that in more detail, but it's a very great perspective.
And basically, so the important point is when you're dealing with patients with substance use disorders, and it helps build the empathy of the resident towards the patient for them to understand and learn about the life traumas that they've been through. Okay, now let's look over here. All right, here I like to ask this kind of funny question. I ask the residents, hey, do you guys think that this rat has a character flaw? Why? The rat is sucking on cocaine. The rat is addicted to cocaine. Everyone laughs and goes, no, and why am I asking this? Because, a lot of residents come in with pre-existing stigma and judgments against patients with substance use disorders. So addiction, it makes a point that addiction, even in us humans, is not a matter of a character flaw, okay? Animals like these, under stress, like our patients who've gone through trauma, they're stressed, these animals are locked in a cage, and they can begin to self-administer drugs just as humans do when they're under stress. Now, once that addiction pathway has been activated, the patient has lost control. And a way to make that point, it's helpful to ask residents to look at the brain diagram. The addiction pathway is mostly beneath the cortex. It's mostly subcortical. It does end up in the prefrontal cortex, which controls executive function, impulse control, and so on. So the first step of the 12 steps, and here's the one from Narcotics Anonymous, we admitted we were powerless over drugs, that our lives had become unmanageable, reflects a neurobiological truth. All right, so how do we screen, a quick screen for substance use disorders is this TICS, the two-item conjoined screen. You ask the patient in the last year, have you ever drunk or used drugs, including prescription drugs, more than you meant to? Have you felt you wanted or needed to cut down on your drinking or drug use, including prescription drugs? If they answer positively to either one, there's an 80% sensitivity and specificity that they are likely to have either an alcohol use disorder or substance use disorder. Okay? Another important way for a quick assessment in primary care is to have your residents memorize what are the 4 C's of addiction. Okay? So let's just go through that. Loss of control, compulsive use, continued use despite harm, and craving. And notice here, you can't depend on physical dependence because, again, that's a normal neuroadaptation. It's not considered abnormal. But it's helpful if the residents kind of really remember these 4 things. They can sort of ask questions from that. It triggers their memory. They don't have to necessarily pull out the DSM-5 criteria. Okay, another thing, obviously, is to look for behaviors, and this is a really tricky area. There's behaviors that are somewhat consistent, and so we're going to pick the highly consistent behaviors that our chronic pain patients may be having that would indicate they may have a substance use disorder. So one is loss of control of use and much adverse consequences related to use. So let's go through this. So frequent lost prescriptions could be a red flag. They show, now this is an important one, they show no concern about opioid side effects or interest in integrative care approaches. When I do consults with these patients and I go over the side effects, if I don't see what I call the IY sign, I get worried because the ones who, have a normal reaction to my talking about the side effects and hyperalgesia and all the stuff we've been just talking about, they should look concerned. So that's one thing, no concern, that's a problem. Preoccupation, obviously, with obtaining opioids for other than analgesia, seeing multiple providers after you check on cures and they didn't disclose that. Here, injecting oral medication. It's very important for residents, while they're treating patients on opioids, to do a physical exam and look for stigmata of addiction, particularly for signs of injection use. Why? Because we're going to have, I guarantee you, and the evidence is beginning to show this, unfortunately, as we lock down on opioid prescribing in primary care, there's going to be a bunch of opioid refugees who are unfortunately going to end up on heroin. And so I think we're going to see a bigger and bigger epidemic come up in that realm. And then obviously these kinds of activities are associated with illegal activities as well. All right. Now, thank God DSM-5 has happened as far as I'm concerned regarding alcohol and drug use disorder criteria. DSM-4 was very confusing, and all of you learned about dependence versus abuse diagnoses, and it was super confusing. And as a teacher, frankly, it was very difficult to teach. We now have just something called alcohol use disorder or opiate use disorder or cocaine use disorder, okay, that sort of thing. So now it's seen as a spectrum disorder. Mild is not addictive, but would be consistent with prescription opioid problem use, okay? So someone may get an opioid use disorder who's not yet addicted but having some problems. The addiction pathway is triggered in somewhere in the moderate zone, okay? So again, it's a cluster of, and by the way, the mild prescription opioid problem use is probably quite common with our chronic pain patients. The actual severe or moderate may be less common. So again, this is a cluster, DSM-5, and is a cluster of cognitive, behavioral, and physiological symptoms indicating continued use despite harm. Here are the DSM-5 criteria. You can go over this. Make sure it's important to put a slide up like this so that people can at least see what the criteria is. I want to mention a couple of things. They added here use despite negative psychiatric or physical impact, or psychological or physical impact. That is actually new, and so that's really important. So patients, for example, who should not be using opioids because they have a clinical depression, even a little bit, that could be a problem. Or, for alcohol use disorder, they have liver disease. For some other reason, they should be off of alcohol, so that would be something. And notice here, tolerance and withdrawal, only for opioids. All the others, it is considered part of the criteria. Why is it not considered? Because, again, this is normal physiological adaptation we expect when someone is on chronic opioid use. So here's a question. What are the risk factors for prescription opioid-induced substance use disorder? Personal history of substance abuse, history of sexual abuse, age less than 45, history of psychiatric illness, or all of the above. Okay, I'll give you a half a second to think about that. Let's hope you all said all of the above. Okay, and the next topic I'm going to throw over to Kelly.
One thing I'll mention is that Christine had let me know that she's done coaching calls with several of you, and one of the things that's repeatedly come up is how do you manage it when lots of prescribers, whether we're talking about the attendings or the residents, have different beliefs about opioids and different abilities to be rigid versus lax, and when everyone is treating the same disease differently, it creates a feeling of chaos in the clinic. Certainly patients never know how they're going to get treated depending on who they land with. Residents get different answers no matter who they're talking to. So one of the things that we'll be doing in our next webinar is really talking about how do you change cultures? What are the basics of quality improvement and changing cultures in a busy, chaotic place? I'm not sure if any of you have read the book Switch by the Heath brothers. And one of the things, the concepts they talk about is how do you actually make people change their idea, or how do you help prescribers change their behavior? And they talk about this concept of a rider on an elephant. If you want, do you appeal to the rider of the elephant who's walking along? The rider might be the rationalities. So in that case, you're trying to appeal to data. You might do an education campaign going through what we're going through in terms of what's the new understanding of addiction. It's not 1% of chronic pain, it's 30%. What's the new understanding of opioids' effect on the brain, how opioids can make pain even worse. So again, helping people through appealing to their brain to change their behavior. Or do you appeal to the elephant? If you've got a rider of an elephant, what do elephants react to? Fear. So sometimes appealing to emotions can help. Doing a report about all the patients in the clinic who died in the last 5 years from opioid overdoses, having people pull up their personal stories of people that they've lost. Sometimes fear comes from comparative data, and I remember the first time I ever got a report from a registry showing my scores on diabetes care compared to everybody else's, and of course I thought I was the best, I was the worst, I was mortified, and then I went to the person who was the best and asked them what they did differently. So we've talked about appealing to rationality through education, appealing to emotions through fear, and one of the most effective ones tends to be what's called changing the path. If you want to change where an elephant goes, sometimes just changing the path in front of them drives that behavior, and that's why we keep reinforcing not just making change through education, but trying to set up systems in the clinic. So an example would be San Francisco General. They started running reports of every cocaine positive urine drug screen, and then doing chart review and talking to the provider about following that clinic's protocol, but what to do about that urine positive drug screen. So again, creating a system that supports the right thing no matter what happens in the room.
And I would say, as a longtime motivational interviewing trainer, you want to find out both culturally and also from the specific clinicians, what's their intrinsic motivations? Why would they want to be making a change? And work with that.
So Christine has put the Heath Brothers book in the link. If you haven't read it, I'd strongly recommend you reading it. I'm going to now go into the buprenorphine. And again, we'll have another time to go into this in much greater detail. We'll just have an entire webinar on understanding it, substance use disorder and addiction, talking to patients about that, having those hard conversations, and then being able to make buprenorphine available for patients who meet the criteria. So one thing is thinking about teaching residents, how do you talk about substance use disorder without it sounding blaming or judging or having that gotcha tone. We certainly have seen many examples of people saying, oh, thank God there's cocaine in the urine, now I can just tell patients I'm not prescribing anymore and it's not my problem. And of course, that's a good way to drive people to heroin or overdose. So there's, again, lots of language in those videos in Scope of Pain about how to talk to patients about this. I can't responsibly continue prescribing. I worry that it's going to cause you more harm than good. You can talk about the signs and symptoms, about why you've made this diagnosis of addiction, just help people understand loss of control, craving, how it's doing them harm. You can talk about it that it's a treatable medical condition. It's a disease, not a moral problem. There's a treatment that can help. Understanding how to explain what happens in the brain with addiction and pain and why that creates some of these behaviors so that people understand the lying and trying to do anything to get the fix, to get the next pill. Doesn't mean they're a bad person. It means that they're in the throes of addiction and that there's treatment that can help. To remain compassionate and empathic and non-judgmental. And I think the one thing that's really hard for residents is setting limits without engaging a power struggle. And so the videos are some good examples of how to remain calm and cool even when the patient's upset. When you're talking to someone and saying, well, if your pain's been 8 out of 10 throughout, no matter what we've done with doses, it's not working, and your pain may get better when we lower the dose. But those are the types of conversations that we want to capacitate people to have. And again, I want to go through a little bit about the evidence of Suboxone. There's a new study that came out of Britain that shows that Suboxone is 6 times safer than methadone when used for treating addiction. There's a ceiling effect with Suboxone because it's both an agonist and antagonist, so it's much less likely to cause respiratory depression and overdose. The evidence is far, far weaker for the things that many of us have seen as the stalwarts of substance use treatment for years. So 12-step complete detox, 30 days of getting people off, getting to detox and then sending them off to do 12-step programs. There's a great article called Dying to be Free that talked about, I think it was the state of Kentucky, which only does abstinence-based treatment, and their heroin deaths, overdose deaths were huge. Because again, if you can imagine knowing what we know now about the brain, if you have a brain that doesn't make dopamine and you take people totally off their opioids, they have one bad day, and what they describe is that suddenly they had a needle in their arm or they have a pad of pills, and they don't remember making that decision. It just has to do with the lack of dopamine, your brain and your behavior becomes differently, and then they take too much because they take the dose that they used to take, and it kills them.
Let me also mention something called PAWS, post-acute withdrawal syndrome, which actually, when patients describe it, it sounds like some blend of depression and ADHD. And in fact, I think you guys are seeing patients are coming in saying, I have ADHD, and if you take their history, what they're really having is post-acute withdrawal syndrome from opiate use. So that, again, is the big driver path. Now, it doesn't mean the other recovery processes, like 12-step work, which I'm a great fan of because I see my patients practicing very well with that, or, a psycho-spiritual approach isn't also important. It's just, and this is important, when people, I want you guys to get this, when people are on opiate replacement therapy, we consider that abstinence. Because they'll say, oh, I'm still addicted, or the family will think they're still addicted. It's abstinence, and abstinence still requires, again, that integrative, full mind-body approach, which addresses, the psychology, spiritual, and relational aspects of recovery.
And so what buprenorphine can do is normalize the brain chemistry enough so people can actually pay attention. Because if someone's in acute withdrawal, or they're not making dopamine and they can't focus, everything that you tell them about recovery is kind of blah, 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 where can I get my next fix?
Right.
You just can't participate. Right. Continuing on to the next slide, we're almost done with the content, and then we'll be going through next steps. Important to know about buprenorphine, the reason it's so effective is the combination of antagonist qualities, feeling for respiratory depression, blocks effects of other opioids, with the agonist qualities. It normalizes the dopamine access. It keeps people out of the highs and lows of chronic withdrawal. Once daily dosing makes it harder to divert. One of the classic things about 3 times a day MS-Con, which is so commonly used. There's a lot of people who take their morning and evening and sell the middle dose to get methamphetamine or cocaine, and it's just much harder to do that when you've only got 1 dose a day. And the interesting thing is it also controls pain. So if there's pain that has to do with all this constant cycle of withdrawal, that will resolve that. So there are ways to get trained. There's online training that's not that expensive, and the CHCF will be working with the state to try and make this more accessible. You can get in-person training, and then that X license gives you the ability to prescribe. There are limits right now in the number of patients you can manage, but there's a lot of effort on the federal level to lift those limits. It can be prescribed in primary care, and like we'll be going again in detail in our webinar purely on buprenorphine. Like anything, it works much better if there's a system and a team approach. If it's just a doctor doing it on their own, it's much harder. If there's support staff around or a team doing it or setting up protocols and systems, it can be much easier. And there's a lot of new ways to do it in terms of setting people up on home induction. There's induction clinics. There's doing it in the clinic. And just as a reminder, you do not need an X license to prescribe buprenorphine for pain. Buprenorphine only needs the X license to prescribe for addiction. So moving along, there's other training available, and we wanted to give you these resources. As a reminder, all of the resources on our Basecamp are available to you to adapt, whether you want to use slides from this slide deck, some more detailed slides that are available on Sharon's full 2-hour presentation, you can use those. And there's several other resources here, and we want to make sure that you know they're available, and we'll be giving you even more on October 1st when we do the scope of pain training. So finally, a note about prevention. These, again, will be in report form on Cures in the next few months. So when you log in, you'll be able to see all of your patients who are at the 90-day cliff, who are going above the high-risk dose threshold. Sometimes you don't realize that they're there because you haven't done the calculator when you're taking 2 or 3 types of opioids, or someone else is giving them those opioids. Mixing opioids and benzos.
And alcohol.
And alcohol. When you look at the death rate, the large number of the deaths from opioid overdoses are either from methadone or adding benzos. Certainly alcohol is a piece of that. And of course, Cures to be able to see if people are getting drugs from multiple prescribers, not as an excuse to fire them, but as a way to have a tough conversation about addiction. And just a last comment, I realize that by our tone, we can, people have accused me of being anti-opioid, and someone's told me once a great line, which is opioids aren't good or bad, they're just a molecule. And as a molecule, they can be used for great things. Certainly if I had a kidney stone, I'd be very grateful for opioids, but they can also do harm, and it's time for us to really understand fully as physicians what the benefit is and what the harm is, so we can inform and protect us.
And I would say, to add to that, look, there are going to be many patients who are already been on opioids for years. They get, a small dose of Vicodin and BID. They function really well. And frankly, in my opinion, we're probably doing opiate replacement therapy. That's okay. That's fine. Don't worry about those folks because they're functioning, okay? So, this is a very complex terrain. And again, if you just kind of focus on functioning, how well is this person functioning? They're getting low dose. Move on, move your resources on to the other folks.
Yeah, and so just in summary, if you're going to summarize everything we've said so far, it's realize how harmful long-term therapy can be and don't start new people, and then look at the people who are really high risk and functioning and work with them. So take the people, do a dose of prevention and not get people started, and take the people who are high risk of death and dysfunction and help them out. And then, Christine, I'd also recommend going to the Southern Oregon pain guideline link that's on the resource page, and you'll see many tools. I don't have them off the top of my head, but there's several different assessment tools that you can look at them and to see if they meet your needs. And of course, in addition, teaching residents how to have conversations with the patients and really understand the history. But again, what I want to reinforce, some of our job is to teach residents to do a good job with history. Some is recognizing with limited time, the more that you can put into a system in terms of standardized assessments that the medical systems do or that are templated, the better you'll see people doing this the behavior you want over and over again.
Can you speak briefly to home induction for Suboxone? I've not heard of this and have only been doing in-office induction, and home induction is considered a standard practice.
Yeah, so it's interesting. I was shocked by this, but Judy Martin, who's an expert in this, told me the patients are more savvy than you think. So if they come in your office, they don't like being in withdrawal, and what I found when I was doing inductions, people would often claim more withdrawal than they had because they really wanted to get the pill, and of course the risk is that they start too early. And what she found is with home induction that people were actually paid a lot more attention to the symptoms and managed it better, and whether it's because they talked to others or they looked at that more. But we will make sure in the webinar that we do on home induction with buprenorphine to go into that, and we can also connect you to Judy Martin's email address, and she maybe has some more information to give you.
Things we're developing here is, which is a first for Ventura County, is Suboxone in pregnancy, so Suboxone during the prenatal and intrapartum period. So I'm kind of heading that project up, and I haven't found a lot of good resources to use in terms of people to bounce ideas off of and get feedback from. I met a little bit with the Suboxone rep who kind of informed me I have to keep Suboxone, the company itself, informed of any pregnant patient that's on Suboxone since it's not technically FDA approved, so I've done that for mine. But if you guys had any contacts or could speak to that specifically, that would be great.
Okay, look up, I'm sure in your research you came across the mother study, is that right?
Yes. Mm-hmm.
Okay, that researchers would be happy to help you.
I mean, I like the fact that ORT is short and sweet, but the modified soap is also pretty quick, rather than this huge soap that they first came out with. So the question is, even the modified soap seems to still have a higher sensitivity and specificity, so is there a reason why you chose to use ORT rather than the short form soap?
The ORT is sort of becoming the standard of practice in most clinics at this point, but you can use either, whatever you're comfortable with.